Welcome. Today we have Dr. Haacke from Wayne State. Mark Haacke is a renowned MRI researcher at Wayne State. He won the gold medal in Kyoto for his 2004 work in susceptibility weighted imaging and education. He's the past president of 2 MRI societies and just formed the International Society for Neurovascular Disease. For the last 30 years, Dr. Haacke has focused on the physics and mathematics associated with the technical developments of new imaging methods and their clinical applications. Dr. Haacke literally wrote the book on MRI. After working behind the scenes, for some 30 years, Dr. Haacke has recently become a public figure as a result of applying his expertise to the study of venous anomalies in MS patients. Dr. Haacke has testified before Canadian Parliament, and his MRI protocols for MS have become the glue tying together the study and treatment of CCSVI in North America. Of the small thousands of MS patients worldwide that have been treated for CCSVI, a growing number have been doing a new dance, the full Haacke, which is performed in an MRI tube with a course of 2 hours. It may be too early to tell if we stand at the beginning of another worldwide disease eradication, but if we are, Mark Haacke will certainly be one of its heroes. We're very pleased to have Mark Haacke here today. Thanks.
Bart, thank you very much. It's a pleasure for me to be here, and I'm going to try to give you an overview today of some of the things we're doing in magnetic resonance imaging that relate to neurodegenerative disease. And at the end of this, I hope those of you who are more from a technical bent from Google will realize that there's a lot of challenges that might relate some of the imaging technologies. You're looking at everything from mapping interests to signal processing algorithms and a lot of other interesting mathematics. Although I won't present the mathematics today, I will close with an overview of the types of problems that need to be addressed in this area. So although some of the things I'll show you today cover a lot of different neurodegenerative diseases in their capabilities, I'm going to focus on multiple sclerosis today. So multiple sclerosis is a disease that we really don't know how it works yet. We don't know the etiology. We have a good idea that it's related to the immunological system. Some people refer to MS as a demyelinating inflammatory disease. There are a lot of drugs that have been developed based on the immunological understanding of MS today, and some of them work to some degree and some of them don't. But as I show on this image here on the right-hand side, an example of an MR scan showing these bright regions in the middle of the white matter, and these are examples of MS lesions. So if you have symptoms of an MS patient and the physician thinks you might have MS, then you'll get an MR scan. And if the MR scans shows you have 4 lesions or more, then he's probably going to say that you have multiple sclerosis. So there are many symptoms associated with this, and fatigue is one of the big ones. There's also optic neuritis. There are other effects, motor effects, where the nerves get somehow modified by multiple sclerosis. And so one of the questions to keep in mind as we look at the data I'm going to show you, is it possible, in fact, that a disruption of the vascular system can lead to most of these symptoms? I'll show you a slide from Canada, even though we're in the United States. I happen to be Canadian, although I'm also an American citizen. But I know the numbers better for Canada. So there's something like 55,000 to 75,000 MS patients in Canada. In a website that we put online about 9 months ago, within a matter of weeks, we had about 30,000 Canadians, which is half that population, access the website to try to see what's going on in chronic cerebrospinal venous insufficiency. Now, in the United States, we have roughly 8 to 10 times, the population here. So you can imagine 8 to 10 times the number of MS patients. So probably 400,000 or so, maybe more, have multiple sclerosis. And of course, around the world, there's probably 2.5 million people that have MS. MS was first described back in 1868 by Charcot. He looks, for those of you who know Sal Sclafani, he looks a lot like Sal. I think Sal has been reincarnated in him. And he noticed that there was scarring and hardening of the sheath around the nerves. He didn't really pay attention to the vascular part too much, but as we'll see in the history of this, a lot of people began looking at the vascular component not long after that. And in fact, in 1903, a fellow by the name of Boris already recognized that there were perivascular hemorrhages associated with MS. A lot of people today actually quote the work by Adams in the 1980s, where he shows that 30% of lesions have hemorrhagic constituents in them. In 1916, Dawson further explained what type of damage took place in MS. In 1935, Tracy Putnam, and this is interesting because Zamboni wasn't really aware of this work initially, he was already sure that the venous component was very important. So he did a dog study, 14 dogs, and he obstructed the small veins in the brain of the dogs, and all of them developed sclerotic lesions. Now, if he'd had an MR scanner back in 1935, I'm sure he would have discovered the Zamboni hypothesis. In 1958, it was confirmed that there were strong linkages to the immune system. And then in 1972, MR imaging came along and really revolutionized the ability to take pictures of our body without cutting us open, as I'll show you in a little bit. In 1987, the concept of imaging the vessels in the brain became clinical practice. In 1997, we further developed something called susceptibility weighted imaging, which focuses on imaging very tiny veins and also the iron in the brain. So it's a form of endogenous contrast agent where we can actually see iron changing the signal. And then in 2009, Dr. Zamboni came up with the CCSVI hypothesis. So he had noticed, after doing this for 65 people, that there were a lot of stenosis of the vessels, a lot of obstructed flow to the vessels. And so this was a very new and important finding that basically complemented the last 100 years of work that I only alluded to. All right, well, that's just a brief introduction. And I apologize if I go quickly through some of these because I'm not sure how many of you are technical, but I'd like to give you a brief introduction to magnetic resonance imaging because it might give you a flavor for what's really going on. So in MRI, you get into a magnet. And when you're in the magnet, this magnetic field polarizes the proton spins in your body. And this is how we basically listen to the music that your body plays when you're inside that magnet. This concept, or some of the concepts I'm going to talk to you about in just 4 or 5 slides, were initially considered by Paul Lauterbur and Sir Peter Mansfield. And both of these gentlemen won the Nobel Prize for this. It was certainly well deserved. So protons are a spin 1/2 particle. They have a charge associated with them. And if a charge is spinning, it generates a magnetic moment. And this magnetic moment basically is such that these protons, if the main magnetic field points up, these protons are spinning or precessing like a top does in the Earth's gravitational field. These spins precess around the main magnetic field. And that information, that concept was developed by Larmor. There's an equation called the Larmor equation. It's very simple. It says that precessional frequency is directly proportional to the strength of the main magnetic field multiplied by a constant called the gyromagnetic constant. And that gyromagnetic constant, by the way, is 42.6 megahertz per Tesla. So at 2 Tesla, you're at 85.2 megahertz. And guess what? We're listening to the music you play on the FM dial because you're getting right up there into that right frequency, right? Yes? Is that constant the same for all materials? No, the constant changes if you're looking at proton versus sodium versus phosphorus. It's different for all of them. And luckily for us, nature was very kind and made that constant for protons fairly big enough that we can actually then measure this effect. So when you look at an MR image, although I won't talk about the quantum mechanics today, you are actually looking at a quantum phenomena. So when I show you this picture, this is really representative of what we're picking up from the spins, the quantum information. So if I put you in a magnet, you develop this magnetization inside your body. It's okay, it's not going to pull you around or do anything, although at very high fields, they've actually levitated tiny frogs based on that magnetic moment that develops there. So a little science fiction, but it's actually true. And so what happens when you get in the magnet, I can't tell you're in there yet because this magnetization just points parallel to the main field. So somehow I need a little bit of physics in here to help me measure the presence of that magnetization. And so what Bloch and Purcell did back in 1946, and they both won the Nobel Prize for this also, was they got this aha, and they said, let's take that magnetization and let's make it precess around a second magnetic field. So what they did is they put in an antenna. So they put in an RF coil, and that RF coil was set up so that they generated a new magnetic field that's perpendicular. It's called B effective in that picture. So that's this. Okay, this is not working, but let me briefly try to bring this to life. That's the magnetic field here. And of course now these spins, they precess around that magnetic field. So you just turn that RF antenna on for a few milliseconds, and then you turn it off. And when you turn it off, the magnetization is now sitting perpendicular to the main field. And now what does it do? It now precesses around the main field like this, just like it was before, but you couldn't notice it. And so you take another RF coil, we call the receive coil, and the receive coil picks up this changing flux. And of course that changes the voltage, it induces a current, and lo and behold, Bloch and Purcell were able to pick up signal from something inside that magnet. And that's what we do when we try to tell if you're there or not. But this still doesn't create an image, and it took 25 more years for Paul Lauterbur to come along and say, well, you know, you've been imaging in a perfectly homogeneous field for a long time now, and you can tell something's there. And for people doing chemistry and spectroscopy, that's all they cared about. However, the people who want to image humans or any other substance need to do something a little bit different in order to create this image. And so what we do is we purposely modify the main magnetic field. So let's say on my left eye, the field is a little bit lower. And on my right eye, the field is a little bit higher. So this creates what we call a magnetic field gradient across space, in this case, say the x direction. And so when we turn that gradient on, we encode those spins. And they all rotate at different frequencies. And then what I do is I turn the gradient, or I can keep the gradient on in this case, and I can read out that data. And as I read out that data, it's going to beat with all these different frequencies. It creates a spectral response for me. It actually sums over all these different spectral components. So what I need to do is, sorry about that, I'm going to go back here. I took out the formal equation I had here. What I need to do is something called the Fourier transform. The Fourier transform takes all this information that's mixed together and separates it out into its frequency components, and it gives a weight associated with each frequency component. And that weight creates the image that we see in magnetic resonance imaging. Now, there are a lot of other features in MR that I can't cover today, but relate to relaxation times, how quickly each of those tissues relaxes back to the main magnetic field. And there are many other properties such as flow, diffusion, and things like that we can't talk about today either. But the wonderful thing about this is that, unlike the anatomy lesson of Dr. Tolp from Rembrandt in 1632, where in those days we had to study cadavers by cutting them from the outside, today we can look at your body from the inside out, and we don't really have to cut you, although we still talk about cut planes and cutting through the body in different orientations. Yes, you have a question?
Sorry, I know you're not going to cover this much, Jeff, but I was actually going to ask about the relaxation times. I'm just curious, what kind of order of magnitude are they on? Are you talking like nanoseconds?
For solids, you're going to be looking at microseconds, milliseconds, things like this. But for soft tissue at something like 1 Tesla, 3 Tesla, for example, we're looking at hundreds of milliseconds for the T1 relaxation times, all the way up to 4 seconds for water, which relaxes very slowly. And then there are T2 relaxation times, which is the transverse component that shrinks back down towards 0 when it reaches equilibrium. These are normally on the order of, say, 10 to 100 milliseconds. They're much shorter. So we usually create the data and sample it within 10 milliseconds or 100 milliseconds. So what can we do with this data? We can create three-dimensional information from this, as I'm showing you here. And if we collect this as isotropic information, it means that I can cut the data this way sagittally, this way coronally, this way transverse. At the moment, we're imaging with isotropic resolution of a cubic millimeter. We can do this now in about 5 minutes. When I first started MR 25 years ago, it took me about 5 minutes to collect a single set of two-dimensional images with 10 times worse resolution than this. Yes, you had a question? I'm sorry, I can't hear you. Can you speak up? No, it's a good question. What we do is we encode, in this case, we can encode 2D. But in what I'm showing you here, we encode the full 3D volume at the same time. That takes 3 different gradients in X, Y, and Z to do that, but it's possible to do that. And there was one other question, yes?
Well, so the size, is it true that the size of frequency case in Fourier transform tells you about the density of material that at the location along the magnetic gradient, which is identical, associated with that particular frequency?
That's correct. The magnitude component of that spectral information is in fact representative of the brightness of the image that I'm looking at here.
And your equation, your diagram is for the 1D magnetic gradient, but what you do in practice is you actually have 3 gradients, and that's how you're able to do it quickly and get 3D information all in one go.
Well, we don't get it all in one go. We actually have to do the encoding step at a time. So what we do is we rotate the magnetization, we do 1 phase encoding. We let it relax. We rotate the magnetization again, do the 2nd phase encoding. So if I have 200 millimeters here and I want to get 1 millimeter resolution, I have to repeat that scan 200 times. So if I can use a repeat time of 5 milliseconds, it takes me 1 second to do that. If I do that again in this direction 200 times, that takes me 3 minutes and 20 seconds to do that. So we can also design the MR sequence to be focused just on something like blood. In this case, this is called an MR angiogram, and here we can actually collect 3-dimensional information throughout the whole brain on just the arteries. This has become a very powerful tool and is used clinically all the time. And the focus for the last 100 years in medicine has been on the arterial side. And people have tended to forget that the other 50% of our function and body is on the venous side. And so why are the veins important? Well, the veins are important because if we are using up oxygen in the delivery of blood to the tissue, and I can tell from its magnetic properties or in other ways what the remnant oxygen saturation is in the veins, I can tell you how well your tissue is functioning. And so this is very important information, and so I've been spending the last 10 years trying to convince people that imaging the veins is a very important thing. So when we get this signal, we get actually complex information. So the Fourier transform, even though we have only real spin density, because of the way this system works, it gives me a complex component which is directly related to the main magnetic field. And we call this the phase component. And the phase is, in this case, also very simple. It's just the same constant gamma times delta B, which represents the change in magnetic field across a voxel, times the time that I image this. And so what we did is we tried to take a look at what these images would look like in an MR scanner. And this is the complex information. This is the phase information, and it's a mess. And so for 20 years, nobody used it. But what we did is we developed a special homodyne filter or high-pass filter that we took and applied to this at different levels of that filter and slowly removed all of this unwanted information. And then you can see here that we now start seeing something behind this. And this information is going to turn out to be extremely important. The fact that I can differentiate these tissues means that there's an increased local iron concentration in there. And we're finding out right now that this level of iron is on the order of micrograms per gram tissue, which is nanomolars of iron that we've become sensitive to in this imaging. So here's an example on a volunteer at 3 Tesla. Here you can see the iron content very well in the primary motor cortex, which is known to have more iron in it than other parts of the brain. So this is becoming very convincing that we're now able to map out the different parts of iron. But iron doesn't appear just in the form of ferritin or hemosiderin in the brain. It also appears in the form of deoxyhemoglobin. So the hemoglobin has shielded iron, so it doesn't show any delta B effect. But when you take the oxygen away from it, it's not shielded anymore. It becomes slightly paramagnetic, just enough that the sensitivity of this MR scanner can pick it up. And so what I'm looking at here in this dark, the dark represents high iron content. It's actually the deoxyhemoglobin in the venous blood. And so now I can start mapping out pictures of the veins with the same type of detail that I was showing you in the MR angiogram before. Now this is a very important part of the brain for the multiple sclerosis patients because this is the thalamus striate area, and here we have the basal ganglia, which you can't see too well in this picture, but you have the caudate nucleus here, and you can see the vessels coming out of the caudate nucleus draining into the thalamus striate vessel. Now this is an image taken at 7 Tesla, by the way, with 200 micron by 200 micron in-plane resolution, so we can do this amazingly well. This is going to be done in 5 or 10 minutes now in a living subject. So what happens in an MS patient? You see these same areas where the veins were draining now look very dark. That's because I'm not looking anymore at just the deoxyhemoglobin. I'm looking at an increase in the iron content, at least we believe that's what it is, that may be representative of iron buildup in the vessel wall itself. It may be extravasated iron. We don't know yet. We haven't really gone in and done the cadaver studies to validate this yet. But this same person was imaged 18 months later, and here you can see that there's an increase in iron content after 18 months, and it's building up backwards along the venous system. So this is why we are in concurrence with some of Zamboni's conclusions that iron does play a major role here. Now, something else we've discovered recently is that in other tissues, there's also iron buildup. This is a small part of the thalamus called the pulvinar thalamus. And we find that about half of the people, especially young people who have severe MS, have this high iron content. Now, normally, neurologists for years have used that very first image I showed you with the bright lesions to say that person has MS. But this is almost now a biomarker for multiple sclerosis. It remains to be proven, but this is our hypothesis at the moment with this new imaging capability. This is an example of a normal 32-year-old showing iron in the substantia nigra, and this is an MS patient with iron in the substantia nigra. In fact, this is so high that it looks like a Parkinson's case. And a fellow named Marian Simka in Europe, I believe back in February, told us at a conference that he had an MS patient that had Parkinson's-like symptoms and apparently treated him with L-DOPA and the patient responded. But why did this patient have Parkinson's-like symptoms? Well, maybe because they had such huge iron deposition in the substantia nigra that caused that problem. So we're really starting to discover a lot of very new things. So to show you a little bit of quantification, all of these little colorful dots here represent normal people between 20 and 70 years old and measuring the iron content here along the vertical axis. And for very young people, you can see there's not much iron content. And as Burton Dreyer from New York says, unfortunately, we all rust as we get older. So because of that, we get more and more iron building up in our brain. And you can see that out here, if I had these type of high iron content, I wouldn't say that's abnormal. But if you're 20 or 30 years old, I would say that's abnormal. And all of the X's and triangles represent the iron content in multiple sclerosis cases. So you can see that there is a dramatic difference between them. We can even measure iron in the lesions. We don't see iron in every lesion. Our data is on the order of maybe 20 to 30%, which is in excellent agreement with Adam's results. But how can you believe me? So let's get to something closer to home for you. Let's go to Stanford, to SLAC, and let's use X-ray fluorescence imaging. And what we did here is we did an MR scan at 1.5 Tesla in Saskatoon in Canada. And we have the magnitude image. We have this phase image I've been showing you so far. And on the right, you have the X-ray fluorescence iron image. So the K-shell, the energy of the synchrotron radiation is set up to be just that of absorption for the K-shell. And it's absorbed. This is 50 micron resolution. And you have really excellent agreement between what I showed you and what we can see studying cadaver brain. So I think we can have some pretty high confidence that if I tell you we're looking at iron, we probably are looking at iron. So susceptibility weighted imaging, this is something that takes that phase information and marries it with magnitude information. So without going into too much detail here, I'm going to have to skip through some of these because I have too many slides and I enjoy talking too much, so that sometimes lengthens my presentation. This is an example at 4 Tesla where we take these images and we combine the phase with the magnitude to show those vessels better. And you can see here very clearly that same thalamostriate area I was showing you. And on the right-hand side, you have results from a cadaver brain from George Salomon, also down here at UCLA. And he injects a dye and then takes a radiographic image of this. And these vessels are about 1 millimeter in diameter. These are about 500 microns, and these are about 200 microns. So now, within a few minutes, we can actually do this evaluation. Instead of having to do it on cadavers, we can do it in living people. And we've tried to apply this to a number of different areas. One of them is to traumatic brain injury. And although MS is very important, and there are 2.5 million people affected by MS, there are 1.5 million people with traumatic brain injury every year in the United States. And that doesn't count then all the rest of the people in the world. Half of those people, we cannot tell what's wrong with them when we image them. Now we're starting to tell what's wrong with them because this new technique is so sensitive to iron that it starts picking up microbleeds that were not seen before in conventional imaging. I think I have an example to show you that later. So here, all of these dark holes are representing small bleeds that have taken place in the brain. And our hope is to eventually correlate this with cognitive changes of these people and other types of problems they might have, motor problems, speech problems. On the right-hand side, and I don't have too much time to talk about this today, is a new technique where we actually are doing an inverse Fourier transform, multiplying by a weighting factor, and then forward transforming to actually create a susceptibility map itself. This is some very nice mathematics applied to Maxwell's equations that have direct implications here for imaging. And this image is basically the same as this, except if I put my cursor here, and this gives me a number now that tells me how much iron is in that voxel. This is an example of the same technology applied to somebody with dementia. In this case, the person was having cognitive problems. They brought him down to scan him. They did an MRA, and it came out very nicely. No real problems here. We did the SWI scan on him, and you see these microbleeds. These are representative of cerebral amyloid angiopathy. It may be that roughly 3/8 of all what people call Alzheimer's, which is really a misnomer because dementia is the correct term. Dementia can be made up of vascular dementia and Alzheimer's, and both may be very different from each other. However, we're picking up this amyloid angiopathy very nicely. And we did a study here at Loma Linda, also not far from you. We did 5 years. We studied 75 elderly people, and we mapped out these microbleeds and this iron content, and we found that 6 out of 16 people who eventually developed dementia, 6 of these people showed microbleeds at the beginning. And you have to forgive my facetious comment here about time to go sailing, because if I have 8 microbleeds in my brain, you scan me, I'm going to go sailing for 2 years, because in the next 2 or 3 years, I'm probably going to have dementia. So this is what we found in that cohort. And so this becomes a predictive mechanism for the breakdown, the angiographic breakdown that's taking place in dementia. Now, we can also use this technology in stroke, where you, of course, also have bleeding. And this is a very nice example where you can see conventional technology has some hint here there's a very subtle brightness in the area of the globus pallidus and internal capsule that suggests there might have been a bleed there. There's nothing on this beautiful T1 weighted scan. There's not even anything on this magnitude component of the SWI scan. But the phase image shows it very clearly. So in that particular case, if we now create the SWI image, you can see where the bleed is very nicely. So this is a third application of that technology. Now, I haven't had enough of my coffee, so you'll know in roughly about 20 minutes from now what I'm going to show you is going to happen here. So this is not decaf, I hope. It's caffeinated. Oh, good. Okay, that's great. Oh. I don't know. Maybe I'll speed up and even go faster. So the thing about caffeine is it's a vasoconstrictive agent. So what does that mean? Well, take a careful look here now that you've become good imagers. And take a look at the image on the left-hand side. It shows these veins very nicely. But take a careful look at my brain on caffeine with 2 shots. Okay? So here, I'll use this fellow. I guess you can see it by the arrows, at least in the one. So you see the white arrow here shows, you can barely see this sort of the wings of the seagull there. And on the right-hand side, you can see those wings very clearly. What happened? Well, because the blood flow slowed down to my brain, and my brain is still eating up at least as much oxygen, and maybe more when you get this hyper, that you're going to see an increase in local levels of deoxyhemoglobin. And so what we're looking at is a functional change in the deoxyhemoglobin in the entire brain with this technology. Now, people also do something called functional MR, which is a totally separate talk, where we can actually, watch what's happening in your brain as you move your hands, and as you speak, and as you think, and you do math. We can actually monitor that type of effect with these technologies. So I'm going to skip the susceptibility mapping part here and go on now to what Paolo Zamboni and his team were really talking about. So what they thought they saw, and they were literally looking outside the box, right? Because the neurologists have lived in the box of the brain for 100 years. So they said, let's look outside the box. Let's see what's happening in the veins. Because if you can't get the blood out, you can't get the blood in either. So if you've got problems on the venous side, it's going to affect the arterial side, and it's going to affect perfusion in the brain. And this is the type of result he found, a narrowing of the internal jugular vein. So I wanted to give a quote and stop here for a minute of the work of Tracy Putnam. And this is something I just enjoy reading. And that is, after he had seen this effect of blocking the veins in these dogs, the last part of his paper in 1935 read, "The similarity between such lesions and many of these seen in cases of multiple sclerosis in man is so striking that the conclusion appears almost inevitable that venular obstruction is the essential immediate antecedent to the formation of typical sclerotic plaques. So you can only ask yourself, how could the neurologists avoid this for 75 years. Well, actually, many of them didn't. There were other people who also studied the vascular effects, and about every 10 years, someone else came along and studied cadaver brains and studied other forms of the venous effect, and they found evidence supporting this concept. So today, in modern times, what Zamboni does is he uses ultrasound, and I'm not going to focus on ultrasound. But his conditions were that reflux, meaning in this case, the blood flow doesn't always flow down towards the heart. Sometimes it goes backwards this way. And if it goes straight backwards, we call it reflux. You can see reflux in the internal jugular veins, reflux in the deep cerebral veins. If you see stenosis like the one I showed you, that's a very bad sign. If there's no flow at all in the vessel, that's a very bad sign. And finally, if he had another interesting condition that I can't do in MR, and that is when you're lying down, the jugulars take over. But when you're sitting up, then the vertebral vessels take over, and the jugular doesn't play such an important role anymore. And what he found in MS people, that wasn't the case. That MS people, when they would go from sitting up to lying down, that the jugular system was not responding as it should respond. So I want to show you an example here of an image. You can see a carotid artery here, and you can see an internal jugular vein here. And this is about 1 centimeter across, and you see it's nice, uniform, normal jugular vein. And this is an example of a technology that we use where we inject a contrast agent into the blood, and we take a picture somewhere between every 8 seconds or every 15 seconds, depending on whose equipment you're using. And so if I can snap this so fast in 3 dimensions, I can catch the blood when it goes into the arterial phase up the neck. And that's the left-hand image that shows just the carotid arteries. And this has been used for 25 years in MR to study people with carotid atherosclerosis. But they never really paid attention to the veins, and most of those people probably didn't have MS anyways. On the right-hand side, we see one of the first cases that was done by in a small town, Jena in Germany, and you can see here that both of these vessels have a little bit of narrowing associated with them. I wouldn't call this severe. It's not always the anatomy that tells the story here. Now, although I'm going to show you a lot of pictures before I get to some of the technical questions, I want those of you who are technical to think about this for a minute. You have 3-dimensional information. I've talked about quantifying iron, I've talked about quantifying blood flow, and you're going to see all sorts of different shapes, if you will, things that could be characterized by the right algorithms to recognize abnormalities in 3-dimensional data sets. These are the types of questions where we need a big focus. We need that focus to take place quickly, and we could solve some of these problems, in my opinion, in the next year or two if we took all the skills that people have in places like Google or other locations. So in this particular case, on the person on the left-hand side, this is actually a very rare example where the jugular vein comes down, gets very narrow, and you can see here there's a stump. That's what Zamboni calls a truncular venous malformation. Basically, when this person was developing, they didn't develop that vein correctly. It was, it was growing, and it didn't connect to the other part. So it's just like a tree trunk, basically. In this individual, the jugular vein veers off and joins into the external jugular vein. Very abnormal situation. So if you want to go in and treat this person, you would go in with a catheter. So an interventional radiologist would go in here, and he would find nothing. There's no way he can connect back up. I'll show you an example in a minute where, in fact, it would have been easy for him to do that. So that the MR scans, the 3D MR information that's available, if you're an MS patient, I would always have an MR scan first. I don't care what the interventional radiologist says, and it's, of course, I think I'm being taped here. You need it. The neurologist will tell you you need it. You need it for treatment planning, because if you don't use this for treatment planning and the surgery doesn't work for you, what are you going to do next? You won't know what your baseline was. You'll have nothing to compare to. So if you get that done first and then you get scanned again after you've been treated, you have that information available to you to follow what's happening. Now, things are very subtle here. Sal Sclafani kindly lent me this one. This was a patient that had a normal width internal jugular, and the first time he did this patient, he couldn't find anything wrong. So he went back in and injected a dye, and here he could see that the dye stopped. And that's because some people also have these flaps inside the vein. And these flaps can open up like this and block the blood flow. If you stick a wire or a catheter up through that, you're going to open it up. So, of course, you're going to think, oh, this fellow's normal. So things are pretty subtle, and this was very observant of Sal to find that. So here's an example of somebody who has a beautiful arterial and venous system, lots of arteries, lots of veins coming down here in the vertebral plexus. And often if the vertebral plexus is highlighted, or if it's highlighted on one side only, that's the development of collaterals. So the brain is smart. If there happened to be an obstruction here, it would develop these vessels to be very large in order to carry out the blood that couldn't go out the internal jugular vein. So even though this may look normal, we have to look at the flow. So this is a technique in MR where we can actually quantify the flow every 40 or 50 milliseconds throughout the heartbeat. So here we make a plot of the flow, the average flow about 10 centimeters per second, and you can see it doesn't go to zero and it doesn't go negative. But on the person who had normal-looking vessels, here's what happens for him. The flow goes up and it stops for a good fraction of the cardiac cycle. Sometimes it even goes negative. And in order to get all that blood out, because the flow wasn't moving for half that cardiac cycle, instead of having an average speed of 10 centimeters per second, he's got to double that speed in order to get that blood out on the way back. So we find that a lot of these people have much higher flow as their peak flows because they still have to get the blood out of the brain. So what we've begun doing here, this is in collaboration with David Hubbard in San Diego, is we've started to make some plots of things like this. And this is just one example of the quantification that could be done with flow. There's probably a dozen biomarkers that can be used for flow. And in this case, we take the ratio of the internal jugular vein flow divided by the total venous flow that we can measure. And in most people, we see that's around 80%. And here you can see some people have very, very low values for this. And so we wonder if this is representative of an arterial-venous mismatch. Are we getting a lot of the venous blood going out, the vertebral plexus? And are these people ones that have maybe more severe MS? I can't give you the answer to that question yet because we're just doing this. These slides are literally hot off the press. I got them yesterday from one of my postdocs. This is another example of plotting, again, the percent reflux here. And in fact, if I could read this versus, yes, the total flow here. So you can see that you tend to have this higher reflux at lower flows and not so high reflux at higher flows. What I need to put on these plots that I don't have yet, and this is the weakness of what I'm showing you, is I don't have 50 normals to add on to this yet. We are collecting normals at this point, but this technology needs to be done on not dozens, not hundreds, but on thousands of people. And as I'll show you at the end of this talk, I think we have the potential to do tens of thousands to hundreds of thousands of people, creating international databases for diseases like multiple sclerosis. So I'm only very briefly going to show you something here, why it's important to deal with this vascular problem. I think it's going to be very hard for you to see this, but when people get acute lesions in MS, these lesions tend to enhance in the presence of a contrast agent, and that's shown here. With some of the new technology called perfusion-weighted imaging and some of the analysis that's being done to measure cerebral blood volume, we find out that the cerebral blood volume for these people is increased in the acute lesions. So the body's trying to deal with this problem. The problem is if you've had that lesion for a long time, you can see here it's just completely dark in this circle. That means that the local cerebral blood volume is almost zero. That's bad news. If you don't have blood flowing to the tissue, that tissue will become ischemic and it will die. So you don't want to have those lesions for too long. And again, I'm going to throw this out as more of a challenge to the technical Google people. So this is a new technology we developed where we take the temporal information we get. We collect basically an image roughly every second, and we take that data as a function of time, maybe over 50 time points. And as that contrast agent goes into the tissue, it has a constant signal first, and then it drops the signal, and then the signal recovers. If I take that signal from one point, and let me say I'm going to take the signal from an MS lesion, I'm now going to do some type of cross-correlation or mean-squared error estimate of the similarity between that pixel and all the surrounding pixels. Then what happens is, here I can see in the red means the biggest difference. I can see that that single pixel I chose in the MS lesion now allows me to pick out all the lesions in the entire 3D volume of the brain. That means they all have the same vascular behavior. So you can see that all of these dark red match here with the bright white. But look at something else. There's a pattern here of green that's not as different as the red that in my mind may be an indication that that's the next tissue at risk. That's all tissue that probably is beginning to develop this same vascular problem. And it may be that if a new lesion develops, this is the region it will develop in. So this is a very new technology, but something that has a lot of promise. So I think we better move on here since I have just 20 minutes left. The venous system is a very complicated system. If you think of it simply, you have such rapid flow in the arteries, somewhere between 20 centimeters a second and a meter per second for the common carotid artery. But the veins, they're much bigger. Why? Because the flow there is maybe 10 centimeters per second. So to have a balance of input-output, you need to have a much higher volume of veins than you do arteries, because the blood flow out of them is much slower. So roughly speaking, there might be 3 times the volume of veins in the brain than there are arteries. And so the body creates a very complicated system to drain that blood. And it's very smart. If the blood is stopped from draining out this region here, which is the thalamostriate region we were talking about, this is the straight sinus, then the body says, okay, if I can't get out there, there's a whole bunch of tiny little plexuses in here. These are small networks of vessels that I can't even measure directly. And it sends them down these plexuses, and it sends them down the spine. So many people with MS, they have this extra outlet. They can develop and enlarge the veins in the spine to take that blood away where they couldn't get out the normal pathways. So let's take a quick look at this. This is a projection over many slices through that same technology, which we called contrast-enhanced MRA. And it's very complicated. In fact, it's so complicated I can't really tell what's going on here. Well, the nice thing about having 3D data is I can narrow that window I'm looking at down to a smaller number of slices like this, or I can narrow it down even further just to look at maybe 5 or 10 slices, and lo and behold, now you can see very clearly that there is a stenosis here, and in this particular instance, the interventional radiologist could go up through here and open that up because there's a connecting pathway between the two. So it's very nice to have that information available to you. Now, again, by proper processing of that data, we can go in and strip away the tissue, strip away the arteries, and we can get an image that contains predominantly veins only. And this is really a gorgeous example of somebody who has developed tremendous collaterals in the vertebral plexus. You can see the external jugular here, the internal jugular. This is that same person who has this internal jugular veer off into the external like this. And because of that, they've developed these collaterals to get that blood flow out. So this three-dimensional information is very important for treatment planning. There are many manifestations of these types of things. Some people have just a thin jugular all the way down. It's not necessarily blocked, but it's going to be tough to get a lot of blood flow out. So what does the body do here? It takes these external jugulars and makes them very fat, so they can carry more of the blood out for you. And it may be that even normal people have this. I don't know yet because we haven't done enough normals. And it may be that this is just a natural protective mechanism and they don't get MS. We can't say that CCSVI is the cause of MS, and I'm not trying to say that, but it's part of MS. And it may be there are other exacerbating factors. For example, low levels of vitamin D, other types of things that may have caused this problem. Maybe you had trauma sometime in your life. There could be a variety of reasons for this. Nevertheless, we cannot ignore the fact that so many MS patients have these types of problems. Some people have multiple stenosis in their jugulars. Some people have bilateral stenosis, as shown here. This particular individual is a very complicated case. Similar to that one person, the jugular is very thin, and then it loops back over and joins into the external, and you can see that the external loops back up here like this. So even just in this short presentation, you're going to see there are many, many manifestations of this. In order to do a proper job, to do what the neurologists want, double-blinded study, you cannot design a double-blinded study until we do what we're doing today. So in fact, to follow the neurologist's own advice, we need this pre-information to do a good job in a double-blinded study. And we need probably thousands, because if we have 25 different types of CCSVI and I want 20 cases per type, then I'm at least 500. And if I have more types than that, then I'm going to be in much larger numbers. So here's an example of someone who has a truncular venous malformation. The jugular comes up and it just stops. So what are you going to do for this? You need this information. Here's the opposite. Someone who has the vessel coming down and it just stops. It doesn't go anywhere. Notice the contrast agent gets in here, but there's no flow past this point. There's no vessel past that point. So again, the body here develops the vertebral plexus to handle that type of problem. Now, sometimes you will find pinchings up in this area for normal people. So again, it's very important we do a lot of normal people, and this will be the next stage of doing this. We've done more MS patients today than we've done normal, so we need to change that. We can also, in 3 dimensions, do something else to validate our understanding. So this coronal picture is nice. But how do I know really the level of stenosis? What I'd like to do is quantify that level. So we can go and look at the transverse data, and we can see that this vessel got very thin. Okay, we call that a stenosis or a narrowing. We'd like to quantify it and say that's 80% stenotic. So those are some things that also will need to be done. The azygos, I only briefly mentioned. We're making progress on imaging the azygos. It's a little bit harder to do that, but I know the MS patients would be interested in that. So I have a slightly different proposal than Zamboni from an MR point of view. What are the criteria we can use? We can look for clear stenosis. We can look for the truncular venous malformations. We can look at lack of flow. We can look for dilated internal jugular veins near the confluence. We can look for stuck valves. We can look for circulatory flow. What we're finding in some cases is that as the jugular comes down, it dilates like this as it's joining in with the brachiocephalic. And there's a circulatory flow that's created like in the carotid bulb. Now that can't be good for that vessel because it's probably constantly putting pressure on that wall, and that's probably continuing to dilate. So the system exacerbates. It gets worse over time, not better. Reflux is important, and very high flow rates are important. So what are some of the future directions? We need to look at combining ultrasound and MR to get better flow information. We need to continue to characterize these venous problems. We need to map out the dynamics associated with this. And the next topic is we need to create an international imaging protocol with this. So what we have proposed is the NICE protocol. It stands for Neurovascular Imaging Center of Excellence. We'd like to see a number of these centers of excellence around the country, around the world. I proposed this actually in January to the Canadian federal government in Ottawa. This is the type of approach that's quite novel, very different than NIH funding, very different than conventional industrial funding. Right now, when we write NIH grants, we could pay up to $50,000 a patient because you have to pay for the doctor's time, the researcher's time, the imaging time, and everything else associated with it. So a recent ADNI study was roughly $60 million to study 800 cases. That's a lot. That's the $64,000 question is why does it cost $64,000 to image one person? So what we need to do is we need to do this 10 times cheaper and 10 times faster. We don't want to wait another 10 years to try to understand this problem. And I believe by properly integrating the efforts that are going on across the country anyways at a level of not just academic environments but clinical environments, we can do that. And this is what I'd like to show you here. So in March, we started to process data for different sites. We did about 100 cases in 4 months. And then the last 3 months, 200 cases. And I imagine we'll do 400 by Christmas, maybe more. And this was just with 3 sites. Now you can imagine that this is starting to become exponential. And remember, there are 400,000 people in the US with this problem, right? So what's going to happen here is this keeps doubling every 3 months. That number is going to become very big, very fast. And so within 2 years, we'll be doing tens of thousands, if not 100,000 cases. I can't handle that. I'm just an academic person. I have a few people working with me to deal with this. I have 3 sites that are working with me right now. I think there's a tidal wave about to happen. And I think people in Facebook and Google, they understand the viral concept. Once you get one piece of information out there and you want to enhance it with a second piece, which feeds back to the first, this becomes exponential very fast. And it's not just an issue of handling the data. It's an issue of processing that data properly and data mining that data properly. So you need enough people focused on this to do a coherent job, not in 25 different centers across the United States, in one center who can focus this together. And I do want to just acknowledge Mark Godley at False Creek in Vancouver, who's been very helpful at working with us, David Hubbard in San Diego, who's helped establish that international IRB, Mylène Terrien, and Jean-Luc Garipier and IRM in Quebec City. They've just started to do this as well. As I said, that's just 3 sites. What's happened in the last week alone, David Hubbard has now got approval for this IRB. So on the first day, we had 3 responses. The second day, 20. The third day, 40. Okay, that's going to really mushroom. If we get hundreds of sites willing to do this, we will be inundated with this. So we have to start thinking ahead. How can we handle this? If I wrote an NIH grant today to say, okay, help me do this, that's great. I'm sure I can do it, and I will submit a grant for this. It will be at least a year before I hear back from them and get funding. So I can't wait a year. We have to do this today. So what are some of the things we need to do? We need to look at 3D automatic processing, things like vessel tracking, vessel identification, functioning, quantification of venous anomalies. This is really pattern recognition problem. Can we see all the different types of patterns that associate with this? We need to quantify the iron content. We need to quantify the lesion types, where they are, how they associate. And we need to basically correlate the subcharacterization of these venous anomalies with flow, iron, anatomy, patient symptoms, and treatment outcomes for the patients. This is a big job. This is a center job. It could take 100 people to handle that. So the conclusions are, can neurodegenerative disease be vascular in origin? Do they contain perhaps instead just major connections to the vascular system? We can answer these questions if we do this in the way that I've proposed by using centers of excellence. This nice database and the establishment of a national registry is, in my opinion, the way to go. We need to be doing tens of thousands to hundreds of thousands of cases, and we need to be doing it quickly. And so my final note to Google is perhaps Google can help establish the next level of integrated national and international research by supporting the NICE Centers of Excellence concept. Thank you very much.
We have time for a few questions, and I hope one of these microphones works. So I'll bring this out, and people can talk.
Well, first, this is stunning work, and thank you for describing it to us. I think we're very lucky to be able to witness this. I have a very simple question. Can you offer opinion, or does the research thus far allow you to offer opinion on whether or not people that have a truncated jugular, say by means of surgery, like a radical neck dissection, if those people are at greater risk for CSVI, as you've described it, or if you just don't know yet?
No, we don't know yet, and part of the reason is this is really novel. I mean, in my opinion, Paolo Zamboni will probably get a Nobel Prize for this in a few years. So you're witnessing something that you only witness maybe every 25 years or so, where there's a breakthrough, a medical breakthrough. The problem is people have run out there and they've got imaged, about 1,000 of them, and they've got the treatment, about 1,000 of them. But they're not being followed up in many cases, or if they are being followed up, like in Dake's case, they're imaged a year later. The numbers aren't there to correlate the types of disease with the final outcome. There are a lot of people now who are finding that they had good recovery for some point after the treatment, but maybe they're going back a little bit. And then the question would be why? What's happening? You won't know unless you do the imaging and try to understand this problem. So maybe in a year I can answer your question. Maybe 6 months, depending on how viral this really becomes.
So on one of the earlier slides, you mentioned like in 1935 they demonstrated the vascular correlation or whatever, and then later on they demonstrated the immune system correlation. So how does the vascular theory affect the immune system theory? Like, are we throwing out the demyelination thing, or is there a tie-in with both? Is one causing the other? Like, what's the story there?
Sure, that's an excellent question. I think that the neurologists today should be very excited about this, because I don't think this rules out the importance of the immunological study. It's the very opposite. I think we should be studying something we could call vascular immunology. And that would be the study of how changing wall shear stress, for example, which is well known in carotid atherosclerosis, to help enhance that problem, that this change in shear stress may end up leading to an immunological response. In fact, the work of John Bergen actually demonstrates in animals that if you change the flow, there's almost an immediate response from the body. And so that could help generate this immunological reaction that leads to T cells, that leads to the tight junctions loosening up, that opens up the possibility of escape into the tissue. So I think these things are probably very closely related to each other. That is an area of important study.
I have a question about imaging the azygos. I don't understand why the azygos images come out so badly compared to everything else.
Imaging the azygos is partly dependent on whether or not the contrast agent is there in enough concentration. And so in the spine, by the time it gets to equilibrium in the spine, the effect of the contrast agent has diminished. Now, there are some new contrast agents out there, one called MS-325, which is about 5 times more powerful than the current contrast agents, and that would be very interesting to try to do that with that particular agent. However, we have other technologies where we can image without relying on the presence of the contrast agent, and that's what we do right now for the azygos. It's a 2D time of flight technique.
Right, but still the images have this sort of horizontal noise component.
That's because what we do, it takes a few seconds each time we image, and if you're breathing during that process, which you are, and we're not going to ask you to hold your breath for 2.5 minutes, then what happens is you just get this offset. And in fact, one of the next things, I've just been too busy to do this, is just to go in and develop a simple registration algorithm that can go and put those back together again. And then the next time I show these pictures, it won't look like it has this little boxy artifact associated with it. Yes.
So for the face reconstructed images, images reconstructed by the face face informations, you're all using the 7 Tesla system, or like?
No, most of the data I showed here is either from 1.5T or 3T. They're clinical systems.
Okay. How about I remember you showed one 50 micron image.
Actually, they weren't 50 microns. That was a conventional 1.5 Tesla scan that showed the presence of bleeds in a 50 micron arteriole. Okay. And because the iron effect is so strong, it can affect something 1 million times the volume that's the source of the iron itself. Okay. And so that makes MR very sensitive to the presence of iron in its highly paramagnetic forms.
Thank you very much for a fantastic speech. I'm a non-medical person, so this may sound a little simplistic. All the heart patients that are imaged for the arterial, is there a possibility, since you need hundreds of thousands of cases, to have the venous flow be done at the same time, so you have a database of a huge proportion of the population?
That's a very good question. In fact, I just spoke with the head of radiology at Wayne State a few weeks ago about looking back through some of the CTA data where people do study the arterial system. And that is, in fact, our goal, to go back and look at a few hundred cases and get out the anatomic information, not the flow information. And that could be done at many different sites to validate that, in fact, normal people don't have these type of truncular venous malformations, or they don't have these type of stenosis that I've been showing you here. And so this is a great way to do it without having to go and image normal people. But to really compare with the flow that I've been showing you here, to quantify that flow, we're still going to need to do a few hundred normals. In normals, we don't need to do 10,000 of them, I think. I think it's the MS cases for characterization we need to be doing the 10,000, 100,000. But we do need a few hundred or even a few thousand normals to validate where they sit in these different types of plots that I showed you related to flow and iron and other characteristics.
Thank you. And I have a second question. In terms of the optical neuritis, people who, multiple sclerosis, who have patients who have undergone the stent, have they improvements in their vision as well?
I don't know the answer to that question, I'm afraid. We need to, again, follow patients after treatment. And there is an international registry that's been set up, by the way, by Paolo Zamboni to try and, in fact, track this information that's present. And we, just a few weeks ago, we formed a new society. It's called the International Society for Neurovascular Disease, that is basically to give us our own political voice to study things like CCSVI. And we will have our first meeting of this society in Italy in the spring of next year that will hopefully start bringing together things like a white paper for interventional radiologists to say, this is how you should be doing the treatments, this is what you should be following, that we can do the same thing for the imaging, so that we have some national, international standard by which people are doing this. It's only for, of course, for the protection and benefit of the patient. All right, thank you.
Question from New York? Can one ask a question from New York?
Oh, okay, yes.
Sorry. As, again, a non-medical person with no experience looking at the images you present and trying to think about the prospect of doing some sort of visual image parsing. Are these images of a class where different radiologists don't even agree on what they mean? You think you could train a high school student to do it, or you think you could train a pigeon to do it?
Okay, that's a very good question. I'm glad you asked that. When we first started processing this data, it took us about 8 hours a case. There are dozens of gigabytes of data, and in fact, depending on how you collect this data, you could end up with a half a terabyte of data. So this was a long processing. I usually had master's students do this. They needed to get trained a little bit in anatomy and other things like this. Since then, though, since I have a lot of computer science students and people like this who also work with me and for me, we've now cut that processing time down to around 2.5, 3 hours. We are looking at automatic registration and pattern recognition type of programs to do this. But of course, you really need a lot of expertise to do this properly. The radiologists, they can tell you if it's a stenotic vessel or not, but they don't know if a person has reduced flow in the vertebral system, for example, or the inability to create collaterals. They don't know yet if that's a bad thing or not. So it's pretty hard for them to make a diagnosis until we can really categorize the relationship of the flow and the vascular anatomy with the actual patient symptoms and patient outcome post-treatment. So this is a pretty complicated process that you could imagine with tens of thousands or 100,000 cases, you could go and run some automatic routine that would then try to pull out similarities between different types of patterns and say that person who can't develop collaterals is at far greater risk than another person and will benefit the most from the treatment. I'm not sure that answers all your questions, but I hope it gives you some flavor for this.
You went way beyond the question I was asking, which was simply how difficult does it seem to be to look at these pictures and conclude there's a blockage here, there's reduced flow there. But I think that was a great talk, and I thank you, and I'm actually going to talk to you in a few hours.
Thank you.
Okay. Anything more from New York or Kirkland?
You mentioned several times, and also in your last sentence, the treatment. What is the treatment?
Well, it's percutaneous transluminal angioplasty, known as PTA. Basically, they go in with a catheter and they can take a balloon and they can expand the balloon to try to open up the narrowing in the vein.
Kind of stent.
No, that's not a stent. It's literally like a balloon. A balloon is inflated, it pushes open the vessel wall, and if you're lucky, it will stay open. And what Zamboni found was about 50% of the people that did stay open. In other people, it recollapsed. If it continues to recollapse, they might need to have a stent put in. But most people today are trying to avoid stents unless absolutely necessary so that they can try the angioplasty, the balloon angioplasty first.
Now, is this brain surgery or is it outside the brain?
Well, this is basically an outpatient procedure. So you can go in one day, you can have this procedure done. It might take 45 minutes. It could take several hours, depending how complicated it is. You will then be followed after this for a number of hours, and I suppose if it's more severe, you might even have to stay in overnight. But I believe most of the time it's considered outpatient treatment. And there is a paper coming out by Murray and Simca who studied 284 cases to demonstrate, in fact, that this is a very safe procedure. Don't forget, they've been doing this procedure in other parts of the body, particularly with people who are on dialysis, for example, in the peripheral vascular system, for many decades. So they have a lot of experience in this area. They just don't have experience yet in the internal jugular veins, per se.
In fact, there are 5 people behind you who had this procedure.
Okay.
Okay.
Thanks.
Great. Thanks. Thanks for coming.